Hi everyone and welcome back. In today's video we're going to review the brand new 2015 PALS Pediatric Tachycardia Algorithm. We're going to review the types of tachycardias that are seen in the algorithm. We're going to talk about the causes of these tachycardias, the treatments of these tachycardias, the drugs and drug dosages that we're going to use to treat these tachycardias. Then we're going to back up and look at the algorithm itself, which gives us a systematic approach to determining what kind of tachycardia we have and how we're going to treat it. So today, pediatric tachycardias and what you need to know. Right in the temple. Who's editing this? Standing right here. It's going to give me a nosebleed. Now in this algorithm, they focus on three types of pediatric tachycardias. A sinus tachycardia, a supraventricular tachycardia, and a wide complex tachycardia. Now, sinus tachycardia. You're going to see these more than any other tachycardia. You're going to see sinus tachycardia in a pediatric patient all day long. Very common. Next, less common, but you're going to see it, is a supraventricular tachycardia. Third, a wide complex tachycardia. These aren't very often seen in children, but you may experience them, so they're in the algorithm and we're going to review them. Now, write down these three numbers: 150, 180, 220. These numbers represent the upper limits of tachycardia for the adult, for the child, and for the infant. And how we use these numbers is a guideline when we're trying to discern between a sinus tachycardia and a supraventricular tachycardia, just by looking at the rate. For instance, let's take a look at the pediatric tachycardia, the 180. If the overall rate is less than 180 in a pediatric patient, it's typically a sinus tachycardia. If the rate is greater than 180, it's typically a supraventricular tachycardia. So just looking across the room, if I got a 4-year-old and I can see that their ventricular rate is 220, it's most probably an SVT. If the rate's only 160, 170, probably a sinus tachycardia. Before we get into the specifics, you can use just the overall rate to kind of get a picture of what kind of tachycardia you're dealing with. First, let's look at sinus tachycardia. What makes a sinus tach a sinus tach? Got one right here, let's take a peek at it. First, the overall rate. Notice it's less than 180. Typically, sinus tachs are less than 180, pretty good indicator. Next, the presence of a P wave. You will see a very clearly defined P wave on your ECG tracing, followed by a narrow QRS. That makes it sinus in origin. Now, a sinus tach is usually caused by compensating for something other than the heart. The heart is not typically the problem. It's something other than the heart that's the problem, and the heart is compensating. A child will try to maintain their cardiac output, their perfusion, almost entirely by increasing their heart rate. Remember our cardiac output formula? Stroke volume times heart rate? Well, if the other problem could be a volume loss, this child has lost some volume, the body will compensate by increasing its heart rate. Causes of volume loss in a child? Vomiting, diarrhea, fever. Then you got the really icky ones, anaphylaxis or sepsis. Again, this sinus tach is trying to compensate for this volume loss, and you're going to find this during your assessment. Asking mom or the caregiver what's been going on with this kid. If you got a 3-day history of vomiting and diarrhea, pretty good chance it's from volume loss. Also, sinus tachycardias go along with that history. They don't pop up all of a sudden. Usually there's something going on with this kid for a while and they're slowly developing the sinus tachycardia. Next, supraventricular tachycardia. First thing you're going to notice is the overall rate. Typically, SVTs in children are greater than 180. Next, no P wave. The rate's so fast you will not see a P wave, so there's no discernible P wave on your ECG tracing. Now, whereas in the sinus tachycardia, the problem was something other than the heart, in an SVT, the problem is the heart. Usually SVTs are caused by congenital heart defects and problems with the electrical conduction system of the heart, either an accessory pathway or a re-entry pathway. So the problem with this SVT really is the electrical conduction pathway. The conduction is coming down, then recycling again. It's recirculating back to the top and causing this tachycardia to develop. Now, whereas in a sinus tach, you may see some variability in the R to R interval. They're hard to pick up, but you may see some. In an SVT, typically you don't see any variability. The heart is on and it's off to the races. Okay, so treatments for the SVT. We know that the heart's the problem and we have to slow this heart rate down. Remember before I was talking about cardiac output, stroke volume times heart rate. Well, there's a point of diminished return with an SVT. What's happening here is the heart is beating so fast that during diastole, the time that the heart is refilling with blood, it doesn't have enough time to adequately fill. So blood comes into the ventricle, and before it can adequately fill, the heart beats again. The heart tries to fill up again, it beats again. So we're ejecting less blood out of that ventricle. And that's really the problem with SVT. Although the culprit is the rate, it's its negative impact on the stroke volume that's really causing that diminished cardiac output. Now, treating the SVT. If the pediatric patient is stable, you can start with vagal maneuvers. Usually a bag of ice water, something over the eyes. We're trying to stimulate a vagus response, try to slow that heart rate down. If that doesn't work, we can move to medications. Our first drug for SVT in a pediatric patient is adenosine, same as an adult. The dose, 0.1 milligrams per kilogram. Rapid IV push followed by a rapid infusion of saline bolus, push that drug to the heart just like an adult. So first, vagal maneuvers, next, adenosine. Next, let's take a look at a wide complex tachycardia in a child. You won't see this very often, but it does present, so we need to talk about it. First, what makes it a wide complex rhythm? The width of the QRS. And we're looking for a width greater than 0.09 seconds. Now, each small little tiny box on your ECG tracing is 0.04, so it's going to be a little bit greater than two small boxes. 0.09 seconds is our threshold. Now remember, an adult heart is bigger than a pediatric heart, so the electrical conduction takes longer in an adult than a child, right? Makes sense. However, we're still using the same ECG machine with the same paper and the same timing. So our threshold, our criteria for wide versus narrow is going to be different timing in the adult versus a child. An adult, less or equal to 0.12 seconds. In a child, 0.09 seconds, simply because it's a smaller heart and it takes less time for the conduction to follow a normal pathway. So again, wide complex in a child, a QRS greater than 0.09 seconds. Now, causes of a wide complex tachycardia, usually congenital heart defects or something called channelopathies. And if you remember from school when they were talking about sodium channels and calcium channels and potassium channels in the heart and the cells, there could be a defect with these channels themselves that is causing this wide complex tachycardia. Now, to discern this, you're really going to need an expert consultation. This is where a pediatric cardiologist gets involved if the culprit turns out to be channelopathies. Now that we've looked at the different types of tachycardias, let's back up and look at the treatment algorithm. First, the stuff we always do. Get them on oxygen, gain vascular access, get them on a monitor, and one of the first things we want to discern is this a wide or narrow complex tachycardia? If the patient is stable, get a 12 lead to discern is this wide or narrow complex. Now, if it's narrow and it's a sinus tach, look for a cause and treat the cause. Simple enough. Are they hypoxic? Is it volume loss? Get a history, find the cause of the sinus tachycardia, and treat it. If it's an SVT, is the patient stable or unstable? And that really guides your therapy when you're talking about tachycardias. Stable tachycardias get treatment, medications. Unstable tachycardias, hemodynamically unstable tachycardias get cardioverted, period. Stable, drugs or treatment. Unstable, electricity, cardioversion. Okay, looking at the SVT part of the algorithm, if your patient is stable, we can try vagal maneuvers, the old ice pack to the eyes. We could try medications, adenosine, 0.1 milligrams per kilogram. But should this SVT cause the patient to become hemodynamically unstable? Immediate synchronized cardioversion. And our cardioversion dosing is half of what our defibrillation dosing would be. So we're going to start about 1 joule per kilogram. Next, is this a wide complex tachycardia? If it's a wide complex tachycardia and your patient is hemodynamically unstable, immediate synchronized cardioversion. Do not delay, start at 1 joule per kilogram, provide immediate synchronized cardioversion. If your patient has developed a wide complex tachycardia, but they're hemodynamically stable, not showing any signs of shock, they're stable, we're going to use medications. We can use amiodarone. 5 milligrams per kilogram, infused over about 20 minutes. And you're watching them. Make sure they remain stable. Another drug option would be procainamide. 15 milligrams per kilogram over 30 to 60 minutes. Again, while we're giving these medications, we are reassessing the patient for hemodynamic stability. Should they become unstable? Synchronized cardioversion. So this has been a review of the 2015 Pediatric Tachycardia Algorithm. I'm Mark. Thanks for watching. I'll see you in the next video.